everyone. I'm going to be walking you through a total hip arthroplasty. So this is a surgery in where they take the acetabulum and the head and neck of the femur and they replace it with metal components. So typically that involves inserting that new metal femoral head and neck deep into the bony shaft of the femur, as well as shaving down the acetabulum for the metal aspect of it, and then putting a plastic disc in between the two to help prevent some of that long-term breakdown that can occur, make the motions a little bit more smooth. Surgeons do have a couple different approaches that they take when performing a THA, the most common being a posterior and an anterior approach, so that's where I'll focus for this presentation. The main causes for someone getting a THA are going to be osteoarthritis or macrotrauma, and I'm going to be focusing on osteoarthritis for this since macrotrauma can happen to anyone. Osteoarthritis is typically seen in older adults as well as women more so than men. And how it works is you either undergo an aging pathway or an inflammatory pathway where the articular chondrocytes, as they age, they facilitate cell death, which can lead to a decreased synthesis of the extracellular matrix and in turn breakdown of the joint. The inflammatory pathway, those inflammatory agents that we've learned about, they're present in this situation, and what they do is activate a cascade of chondrocyte heterotrophic differentiation, which leads to breakdown of the extracellular matrix and breakdown of the joint itself. As this breakdown accumulates, the need for a THA gets higher and higher. If you see these patients in clinic, then you can use an LEFS outcome measure. Just in general, it's very common, but it is valid. Or if you want to get more specific to patients that have undergone a THA, you can use an Oxford Hip Score or an OHS. So the precautions and contraindications that you're going to be following for these patients are going to be specific to the surgical approach that was taken. So you can either have, with the posterior approach, hip flexion past 90 degrees, hip adduction or hip internal rotation precautions, or with the anterior approach, you can have hip extension, external rotation precautions, as well as no bridging and no prone positioning for patients with an anterior approach. So anything in your exam or pre-mobility screening, anything like that which requires those positions, should be modified. So for example, you can have the patient roll to the side, not on top of their sutures, but to the unaffected side, to come sitting edge of bed instead of the long sit method, which may break their hip precautions. The surgeon will also set a weight-bearing status, and the surgeon will progress it as they see fit. So following whatever the weight-bearing status is going to be key to keeping pain to a minimum and to facilitate proper healing. So that could mean modifications with gait, balance training, transfers, anything like that, and assisted devices are great tools to use with these patients in that particular situation. During your physical exam, you won't need to take any kind of extended history, any huge systems review or review of systems, anything like that. Just your standard due diligence, just to make sure you get a picture of the health status of the patient. But since they're coming from surgery, you already know where they're at. You do need to do a pre-mobility screen of their other 3 limbs, as they'll be supporting that affected side. On the affected side, when you're doing active and passive range of motion, it will more than likely be painful, but it should be smooth. There might be muscle guarding and anything like that. They may not want you to move them, but the quality should be pretty good aside from that pain. Again, following hip precautions, whatever they are, not going past whatever the surgeon has stated. You won't really need to do any resisted testing for this population. It's typically not done, again, just to promote that proper healing, just like as they're non-weight bearing as soon as they get out of surgery. Again, you also won't need to do any special tests since you already kind of know where they are. There's not a whole lot of differential diagnosis going on. During palpation and observation, you really need to look at that incision site. Make sure that it's healing normally. Make sure if they still have sutures in, there's no signs of infection, anything like that. There might be some edema there. There probably will be some either bruising or redness or just signs from the surgery themselves, as it is a fairly aggressive surgery. So you can palpate around that. You'll also probably see tissue restrictions. So in their fascial mobility, in skin mobility and muscle play, things like that, those will probably be restricted at least a little bit, as well as tender and could be painful just to the touch. Sensation and neurologic testing should all be intact. There may be some damage right along that incision line just due to the nature of the surgery. Anything that seems kind of out of whack may be referral back to the physician. So any signs of infection, you should also be checking for DVT, as patients can be fairly immobile shortly after if we don't get to them in time. The other thing that might happen is that femoral head could dislocate, so you can palpate for that, and typically you'll be able to feel it. Also, if there are significant differences in leg length, it could be a problem with the metal prosthesis that they put in, so you'll need to check, and it could be a referral back to the physician. As with any patient, trust your gut and clinical reasoning. Thanks for listening.